right, so we're going to get started with our second half of the morning session. First up, we have Dr. Cameron Gill, who's one of our interventional cardiologists. He's been at the university a number of years now, does a lot of things. The topic of his presentation is going to be therapeutic hypothermia, which is a really important topic. We're learning a lot more about it and its utility in cardiovascular emergencies. Then after that, we have our VAD management team, because we have a very active transplant program and a lot of patients have VADs here in the Jackson metro area and throughout the state. So it's very important that you guys know about that. That'll be given by Hope Russell and Jennifer Overton. And then we'll have Dr. James Cobb, one of our ER physicians, talk about hypertensive emergencies. So without further ado, we have Dr. Cameron Gill.
Hey y'all, thank you so much. So therapeutic hypothermia, that sounds painful, doesn't it? So I will try to make this as interesting as I can. So those of you who don't deal with patients that would be getting this, generally speaking, if you or your mom or dad or grandma or grandpa or whoever are, feeling lucky at the Silver Star pulling slots and has a cardiac arrest, one thing that has been shown to make you survive probably better than just about any other intervention is cooling your temperature down to about 90 to 93 degrees or so, right? That is about the same mortality difference as putting a stent in somebody who's having a heart attack, just to give you a reference. So even though you may not be familiar with it, even though some of you are, it's a pretty big deal, all right? So what we're going to talk about is look at the pathophysiology of how this occurs, all right? Why it injures the brain and why therapeutic hypothermia may mitigate some of that damage. We're also going to talk about the landmark trials. The trial slides are always painfully boring with p-values and other stuff, but the reason that the trials are important is because everything that we do to people is based on the way they did it in the trial. So it's not, we may be doing things wrong now, but because they did it that way in the trial, that's all we have to go by. So just to give you a reference of where the numbers come from, why 32 or 34 degrees Celsius, right? Why 24 hours versus a week of cooling people? Give you a reference of where that stuff came from, and look at the current guidelines, because some of them are a little surprising. And of course, guidelines are always kind of in flux. So anoxic brain injury, it's very bad, right? Within just a couple of minutes of losing blood flow to your brain, you start depleting glucose stores, your ATP, your energy source starts to drop, you start damaging cells, damaging mitochondria, you lose the ability to regulate calcium. Why does that matter? Well, when high levels of calcium build up in the cells, that cell's probably going to die, either short or long term. That intracellular calcium causes necrosis and programmed cell death, all right? So anoxic brain injury is bad. Well, you would think, okay, well, let's just get some blood to their brain, right? That'll fix it, right? Well, yeah, you need to, ROSC is return of spontaneous circulation, by the way. That little acronym comes up repeatedly. So once you return spontaneous circulation, that's great, right? You got to do that. The only problem is nothing's free, right? You put the blood back in the brain, and now it starts creating these free radicals. You get this reperfusion injury with free radicals, inflammatory mediators that just kind of put the brain in meltdown. They're almost or more damaging than not having blood in the brain the first place. The brain starts to get edematous because of all the inflammation, and even when you've got normal oxygen levels in the brain, you still may have ongoing ischemia. So anoxia is bad, but reperfusing it isn't a whole lot better. You just kind of have to do it. So therapeutic hypothermia, this is not a new thing, all right? So this is a picture from the late 1700s, early 1800s of a practice in Russia, places where there would be snow available most times of the year. People that had various types of medical conditions. There was some feeling, appropriately so, that if you packed these people in snow, right, that sometimes they'd live. So this is not a new concept. Packing people in ice to slow metabolism for all sorts of really bad things, sometimes it worked. In the 1940s, 1950s, the practice of deep hypothermia with brain, with neurologic surgery, with cardiac surgery was fairly commonplace. And this is a team, I don't know if it projects well, but there's a patient in this trough, and they're packing them down in ice before a thoracic procedure. So therapeutic hypothermia, it prevents the hypoxia by reducing the metabolic rate. So if you take the brain's foot off the gas and just slow down its metabolism, well, it won't generate as many of these free radicals. It reduces the inflammatory mediators, it lowers lactate levels, It reverses the apoptosis or programmed cell death, at least to an extent, right? Not completely. And it reduces cerebral edema to allow better perfusion of the brain. So it does a lot of things to prevent that reperfusion injury that can be devastating. So it's interesting. This is a flyer from 1964, all right? And it's interesting. There was a guy named Peter Safar who was one of the pioneers of CPR. And even though, the whole ABC thing, right, the kind of just resuscitation algorithm was around back then, this guy was really a pioneer. In 1964, in this publication from the Iowa State Medical Journal, look at this. He recommended hypothermia. He recommended mild hypothermia, right about in Fahrenheit, about 90 to 93 degrees Fahrenheit. This guy in the late 50s, early 60s was recommending mild hypothermia for cardiac arrest. Not brain surgery or heart surgery where they knew deep hypothermia worked, but this guy, based on prior literature, said, we really need to do this. The problem was it didn't really catch on. After about the mid-1960s, the practice at that time was they're like, well, if a little bit of hypothermia is good, we're just going to freeze their asses off, right? We're gonna take them down to 20 degrees or so Celsius. Well, that in cardiac arrest, that had bad outcomes. When the heart gets that cold, it tends to fibrillate, it gets very irritable, plus other organ systems didn't really like it either. So from a cardiac arrest standpoint, it was a bust. So because they started cooling people too much, too deeply, it lost favor, all right? So it fell out of favor, even though this guy was really kind of a revolutionary, advocating it for basic resuscitation back even in the late 50s, early 60s. So this is a trial from, I think, 1959. And this was really the first, it's not good data, but it was the first kind of attempt at a trial in cardiac arrest, okay? They were doing it in surgeries, right? Heart surgery, brain surgery, but after cardiac arrest, that's what we're really interested in, all right? So this was the first trial. And it's really a pretty lousy trial. But look at what it shows. There were 19 patients with out-of-hospital cardiac arrest, okay? OHCA, out-of-hospital cardiac arrest. So grandma at the Silver Star, keels over in VFib. So they were comatose, meaning when they got to the hospital, they weren't like, hey, how you doing? Oh, God, don't freeze me, right? They were comatose because you can't freeze somebody who's awake. And they cooled them to about 30 to 32 degrees, which is about 90 to 93 degrees, right? That's pretty chilly, but, not ice box. They did it. It was variable how long they did it, anywhere from several hours to several days. But look at this. Of the 12 patients that got cooled, okay, 50% survived neurologically intact. That was unheard of, right? You're looking at a mortality, generally speaking, back then of probably, 20, I'd say about 80 to 90% mortality, okay? 50% of people that got cooled lived neurologically intact. So amazing. And of the 7 patients who weren't cooled, only 14% survived with various levels of neurologic impairment. So it's not a randomized trial. The data's real weak, right? But it suggests that therapeutic hypothermia to a low level, kind of low 90s, might really make people live, when they otherwise would not have. So things were kind of quiet through the 1960s, 70s, and 80s because, like I said, they just took it too far. It hurt people, and they said, we're not doing that anymore. In the early to mid-90s, 2 trials were initiated, and they were both published at the same time in 2002 because the trials took 5 to 8 years or so. So 2 trials were published in 2002 in the New England Journal of Medicine. And the reason this is important is because these are the 2 trials almost everything we do is based on. These 2 trials, all right? So let's look at them. This trial by Bernard, it was in Australia, the mid to late 1990s. It was randomized, it was controlled so that the quality of the data is good, okay? We should be able to believe this. It was a fairly small trial, 77 patients, not huge. That's a little bit of a limitation. And this was out-of-hospital cardiac arrest with something that is shockable. The reason that's important is because if it's not a shockable rhythm, PEA or asystole, you're probably just going to die. No matter what you do, all right? You can't live forever. Everybody dies of something, and it usually ends in asystole or PEA. So this is out-of-hospital shockable rhythm, right? These are people that if you just shock them with an AED, they could be right back, playing the slots later that evening. Maybe. They were motivated. So return of spontaneous circulation, persistent coma. They cooled them to 33 degrees. This was based on data from the 1950s, early 60s, and animal data. So, not horribly cold, right? But pretty chilly. They got them to their target temperature, or they initiated the cooling pretty quick. That's important because part of the question is, how soon do you need to cool these people, right? Can you wait till the next day, immediately, Well, they did it. They tried to start within 2 hours. They did it with ice packs. They didn't have the indwelling cooling catheters that we have now. They cooled them for 12 hours. That number is important because where do we get why not 8 hours? Why not 2 weeks, right? Well, they used 12 hours, and then they rewarmed them pretty slowly. Look at this, all right? Let's look at mortality. So in the therapeutic hypothermia group, 49% lived, right? 51% died. So about half the people survived to hospital discharge, hypothermia. Compare that to a 68% mortality rate in the group that did not get hypothermia. Okay? So there's a trend towards lower mortality. It didn't reach statistical significance, all right? So even though there was a trend towards better survival, not significant, but let's look at the neurologic outcomes, because if you live through the hospitalization but you're neurologically devastated, that's not really a net gain, all right? So of the hypothermia group, 15 people had almost no neurologic disability at all. 6 had a little bit. They could live independently, but they may need help with a few things. But of the people of this group, if you lived, almost everybody had pretty good neurologic function, all right? Compare that to the group that did not get hypothermia, all right? Even though there was not a huge difference in mortality, the ones that did live, there was only a 26% of that group that actually had good neurologic function. Whoops. And it was statistically significant, and the number needed to treat was only 4. Meaning, for out-of-hospital shockable rhythm, you only have to chill 4 people to preserve 1 person with intact neurologic function. That's not, to give you a reference, a lot of the medications that cost hundreds of dollars a month, like a number needed to treat of 50 is pretty good, right? That'd be a blockbuster drug, all right? So number needed to treat of 4, that's gigantic, okay? That rivals PCI in a STEMI. So the second trial published in the same journal was the hypothermia after cardiac arrest study. It was a European study, 5 countries, late 90s, randomized, controlled. It was similar to the last one, but it was bigger. So 270 patients. Again, these are shockable rhythms that had persistent coma. They cooled them to about 32 to 34 degrees. They tried to do it pretty soon, but sometimes it took 4 to 8 hours to get them cooled down to the target temp. That's important because that kind of tells us our reference for what we need to do to people. They cooled them for 24 hours, where in the last trial they only used 12, right? So they're cooling them a little bit longer, about the same temperature. Let's look and see what happened, all right? So for favorable neurologic outcome up here, all right? For the hypothermia group, 55% had a favorable outcome compared to 39% if you didn't get cooled, all right? That was statistically significant, and you only had to treat 6 patients to gain 1 person with a good neurologic outcome. Let's look at mortality, all right? So 41% mortality in the hypothermia group versus 55% in the group that did not get cooled, all right? That was also statistically significant. You had to treat 7 people to save 1 life. That's a big, big deal, all right? This is just a graph showing the same thing. This is just looking at survival. And, the survival, the curves stayed separated out to 6 months. And let's look at this. So we know that it saves lives. You have to treat about 7 people to save a life. You have to treat 6 to gain 1 neurologically intact person. But what kind of harm does it do, right? Well, let's take a look at the side effects of therapeutic hypothermia. So if you look at these, there was a higher incidence of bleeding in the hypothermia group, but it was not statistically significant. There was a higher incidence of infections, pneumonia and sepsis, but it was not statistically significant. Why would that be? Why would you get these complications? Well, the coagulation system does not work as well when you're cold. When you're not at body temperature, right? When you're not at 98.6, you just don't clot as well. It affects platelets, it affects clotting factors, so you bleed a little more, but it was not statistically significant. Why do people get more infections? Well, in the group that got therapeutic hypothermia, that's an extra central line, probably in the groin, that's going to sit there for about 36 to 48 hours. that can't help. And we know that lowering temperature, what happens when you get an infection? Which way does your temperature go? Up, right? The immune system works better at high temperatures. At lower temperatures, it actually impairs the immune response. So it makes sense that infections are a little bit higher, but it was not statistically significant. So we have determined, I think, that for out-of-hospital shockable rhythms, cooling is unequivocally good. You treat 4 to 7 patients, you save a life, neurologically intact person, right? No argument about out-of-hospital shockable rhythm. How about out-of-hospital non-shockable rhythm, right? Everybody's got to die of something, and a lot of people that EMS comes up on, they're just at their terminal stage of life. So to give you a reference, on average, out-of-hospital cardiac arrest, you got about a 90% mortality, in-hospital mortality, right? It's miserable. So what happens if you cool these people? Wouldn't it make sense that if you cooled their heads that they would, they might, the mechanism should be the same for neurologic preservation. Let's cool people with non-shockable rhythms and see how they do, all right? So this was a more recent article, 2011. So it was in Paris. This was in a large hospital in Paris where they had therapeutic hypothermia already in place. They had a protocol, right? This is recent data. This wasn't how should we do it. This is, we have a set therapeutic hypothermia protocol, and let's just see what happens to, when people come in, let's just cool everybody that comes in. The next, 1,100 patients, we're going to cool everybody no matter what your cardiac arrest was, and let's see if it helps, right? So it was 20, they cooled them to the regular temperature, right? 32 to 34 degrees, 24 hours. That's legit. We like those numbers. Let's look and see what happened, all right? So in the VF and pulseless VT group, so these are the shockable people, all right? Look at this. In the hypothermia group, you had a 44% survival versus 29% survival and no hypothermia. Those numbers match up pretty good to the other studies, don't they? That's about what we saw in the other studies. The reason that's important is because we're saying that the methods they used, those gave us the same numbers in our shockable people, since this wasn't randomized, right? So let's see what it did in the asystole PEA people, so non-shockable out-of-hospital cardiac arrest. If you cooled them, 15% of people survived. If you didn't cool them, 17% of people survived. That's about historical numbers. Whether you cooled them, didn't cool them 20 years ago or today, those are about the numbers you get with out-of-hospital PEA asystole, because those people just are probably going to die, okay? So this trial suggests there is no benefit to cooling out-of-hospital cardiac arrests that aren't shockable. However, there is one small randomized trial, I want to say like 40 patients, that showed some benefit. There was another small prospective cohort study that showed harm. And there are 2 or 3 studies that show it's a wash. Okay? So the data for this is very bad. There is no good randomized data for out-of-hospital non-shockable rhythm. It's mostly a bunch of garbage, okay? But there's a little stuff saying it might be good, a little stuff saying it might be bad, and several studies saying it doesn't really seem to matter. All right? The reason that's important is when you see the indication for cooling these people, you will be surprised on that data. So in-hospital cardiac arrest, everything we've talked about is out-of-hospital cardiac arrest, okay? What happens when people code in the hospital? Totally different game, right? Those people have probably got about a 60-second, maybe a couple of minute downtime, assuming they're on telemetry for cardiac arrest, right, before CPR started. So the mechanism could be totally different, right? You're going to have much less anoxic brain injury because they're just not down long enough. Well, looking at this trial's from 2016. This is not randomized. There are no randomized trials for this. This is the best we got. So in this 2016 article, the survival to discharge, if you cooled them for, you got shockable and non-shockable rhythms here, right? So for non-shockable rhythms, PA, systole, in hospital, there was no difference between the two if you cooled them or not. If it was a shockable rhythm, no difference if you cooled them or not. They did equally well or equally bad, depending on how you want to look at it. Cooling them didn't seem to really have any net effect. So for neurologic recovery, so let's say that, you survive, but, do you gain any neurologic recovery? Again, between hypothermia and no hypothermia, there was no difference whether you were shockable or not shockable. And there was no difference 1 year survival either, okay? There was a little bit of a trend, if you look, there's a little bit of a trend in every subgroup towards doing better with cooling, but it was not significant. A trend, but not significant for in-hospital code of any type, okay? Assuming that they are still comatose. So look at this. which of the following, according to the 2015 ACLS guidelines, which of the following has a class 1 recommendation for therapeutic hypothermia? The TTM is targeted temperature management, okay? So which do you think? Out of hospital VTVF. Yeah, the data looked good for that. How about out of hospital non-shockable rhythm? In hospital shockable or in hospital non-shockable? All the above. Class 1 indication, meaning do it, okay? By the 2015 ACLS guidelines, look at these numbers. Look at the criteria first. You have to be comatose, right? You can't be awake. And they define comatose as not following verbal commands, right? These people will probably be intubated, but if you can't follow a verbal command meaningfully, you are defined as comatose. Not withdrawal to pain, not following verbal commands. Doesn't matter if you're sedated, right? You're not following verbal commands, you are comatose as they define it, all right? You have to be an adult. Therapeutic hypothermia has never been shown to be beneficial in people under 18, by the way. In their trials, for whatever reason, in kids, it just doesn't seem to work. If anything, it has more harm associated with it. So you have to be an adult, comatose. You have to have a circulation again, right? You don't cool dead people. And it has to be a cardiac arrest, not a respiratory arrest or something, right? So class 1, level of evidence B, meaning good quality evidence from randomized trials. Good evidence, R is randomized for out-of-hospital cardiac arrest shockable. But they give it a class 1 indication for non-shockable rhythms or in-hospital rhythms, which we already said the data is garbage. Right? The data is pretty garbage, and they acknowledge that. They give it a level of evidence C, which is the lowest evidence that you can give. The definition is weak evidence, or very weak evidence in this case. And EO is expert opinion. They're saying the data sucks, but it didn't show any harm. There aren't many trials showing that it hurts people. It doesn't cost a whole lot. It doesn't utilize a tremendous amount of resources. And because the neurologic devastation is so horrific if it occurs, we need to have a low threshold to do it. And if the person's going to die anyway, it's hard to hurt them, right? So they basically said, even though the data is admittedly horrible for cooling non-shockable out of hospital or anything that happens in the hospital, we still think you should do it because what's the worst that could happen, right? So it has a class 1 indication, but they acknowledge it's really weak evidence. I'll tell you, it is not our practice to generally cool these people. It's more of a physician discretion thing for the out-of-hospital, non-shockable, and in-hospital stuff. And most of those people don't at our institution. Maybe you're right, might be wrong. Exclusion criteria. So who should not get therapeutic hypothermia? Anybody who's obviously DNR, right? Somebody with severe baseline cognitive deficits. Any cognitive impairment that isn't due, if they're comatose, not due to the cardiac arrest. If they're likely septic, you don't do it, because we've already said you kind of are freezing the immune system with hypothermia, right? So if you think they're septic, don't cool them. If they've got an underlying coagulopathy, recent surgery, they're already bleeding, don't do it. You will make that worse, okay? That is not the same as somebody coming out of the cath lab on heparin and dual antiplatelet therapy. They're fine. You cool those people, right? But people who have just an intrinsic coagulopathy from whatever's going on, you don't cool them. Traumatic arrest, bad idea. And the last one, you got to be able to maintain a blood pressure that's pretty respectable for a reasonable period of time. You got to show that you're reasonably stable even on pressors, because therapeutic hypothermia makes your blood pressure sometimes quite labile, induces bradycardia. So if you're barely hanging on hemodynamically to start with, therapeutic hypothermia is probably going to help that. Okay? It's not going to be a net gain for you. So you got to be reasonably stable for about 30 minutes or so. On or off pressors, doesn't matter, but you wouldn't do this to somebody with ongoing CPR, flagging despite, being on pressors. They got to have a little bit of momentum. How am I doing on time, Mel?
23 minutes.
I'm at 23. That makes sense. All right. Is sooner better? So what if we cooled people before they got to the hospital, right? Wouldn't it make sense that if your brain has got free radicals melting it down, the sooner I can cool you, the better off you'll be? That makes sense. That stands to reason. So let's try it. So this was a trial in Seattle, big trial, randomized, good data, and it was all types of cardiac arrest, shockable, non-shockable, didn't matter. Half the people, they gave a liter or two of 4 degrees Celsius saline, a liter or two of really cold saline. The other half, they didn't. Just it was standard therapeutic hypothermia protocol when they hit the door at the ER, okay? And it worked. As far as the people that got the pre-hospital cold saline, they were 1.3 degrees cooler, which is a lot. In Celsius, that's a lot, okay? And they got to their target temp an hour faster. So it cooled them down faster. So surely that's going to help. But it didn't. When you look at survival, there was no difference in the people, shockable or unshockable, who got the pre-hospital cool saline, even though it unequivocally cooled them down much faster, okay? Much faster. It did not make them live longer. It did not help their neurologic recovery, which doesn't make any sense, but it didn't. That's the data. It's good data. Did it hurt them? Well, a little bit. The group that got the saline had a significantly higher incidence of repeat cardiac arrest. It took longer for them to get to the hospital, probably because they were having to screw around trying to get the saline going. So it delayed them on average about 2 minutes. There were more people that required diuretics, and there were more people that had pulmonary edema. Did it increase mortality? No, not at all. Right? Mortality was a wash. Neurologic recovery was a wash. But it did increase a couple of small complications. Now, is sooner better? Well, it might be. It makes sense that it is. Maybe that's just not the way to do it. That's all that tells us, right? Maybe you should do something instead of giving them a liter or two of saline in the ambulance. You know, maybe you should pack them in ice. Maybe that's the answer. But all we know is that as of this moment, pre-hospital cooling is a level 3, meaning do not do it, indication. No pre-hospital cooling. Based on just one trial that to me just says don't give them saline. But that's all we got. So that's what we go by. Is colder better? How about is warmer better? This was a trial where, you know how we were talking, most of these trials are 32 to 34 degrees, right? That's about 90 to 93 degrees Fahrenheit. What happens if we only cool them to 36 Celsius, which is about 90, a little less than 97 Fahrenheit? About a little less than 97 Fahrenheit. That's not that cold, is it? A little less than 97? Look at this. Deaths at 6 months. No difference. If you cooled them to 32 degrees or just to 36, just a little below your normal body temperature, outcomes were the same, which is good, right? Neurologic function, also equally good. There was no advantage to cooling them to 32 to 34 versus 36. So this says, hey man, if you can get their temperature to like 90, I think 96.8 is 36, right? If you get it to 96.8, you're just as good off. Now, you got to keep it tight at 36. You can't be like, oh, it's 36, now it's 37, now it's 30. They regulated this on the money. It was 36 or a little bit below. But you don't, colder is not necessarily better, and this is good because there's less shivering, there are less side effects. Everything is better at 36 compared to 32 to 33. Getting to the end of it, all right? How do you initiate the cooling? When they first come to the ER, right? You can pack them in ice, cooling blankets in the cath lab, whatever, but sooner is probably better once you get to the hospital. Pack them in ice, cool them down. The regulated devices, right, the device that can adjust itself based on what temperature it's getting, those are obviously better, but they don't cool as quick as packing in ice initially. So when they hit the door, pack them down. Then when they're starting to cool with that, get your kind of maintenance device in, right? It doesn't matter whether it's a surface device that can track temperature or the indwelling ones, even though the indwelling ones are very nice and effective. They're equally good. Pick a temperature. 32 or 36 doesn't matter. 34, whatever. Anything below 36. When would you not choose 36? Well, a lot of people, when they come in straight off the ambulance, they're already hypothermic, right? Being in a cardiac arrest kind of makes your room temperature a lot of times, okay? So if your temperature coming in the door is 35, are you going to warm them up to 36? No. You would probably say, you're 35 right now, why don't we take you to 33? If you come in with a temperature of normal or hyperthermic, well, maybe 36 is good. So the temperature you select is probably based on whatever the temperature they are when you see them, right? If they're hot, 36 is good. If they're already hypothermic, take them down a notch. Maintenance. You want to keep your temperature at 32 or whatever you set it at, right? You want to maintain that for at least 24 hours. We don't know if longer is better, but we know at least 24 hours. Most centers, it is 24 hours. And you're going to cool them for 24, you're going to warm them up for another 8 to 12, and then just leave the cooling catheter in for a total of 48, just so they don't get rebound fever for the first 48 hours, then pull it. All right? So in summary, according to the 2015 ACLS guidelines, if you have a cardiac arrest anywhere of any form, it's class 1 indication, even though that's not necessarily our practice, okay? Pre-hospital cooling has not been shown to be beneficial. Of course, it didn't increase mortality, so if you wanted to cool them before you got there, it's up to you, but it's a class 3 indication as it stands right now, meaning don't do it. Cool them as soon as possible. Sooner is almost certainly better. We just don't have a lot of data to show it, but it makes sense. Pick your temperature, minimize the fluctuations, Pick a temp and stick with it for 24 hours. Pick your temp based on what they were coming in. Keep it for 24 hours. Anticipate problems with electrolytes as temperature changes, blood pressure swings, heart rates change, glucose goes crazy. Most people are on an insulin drip. And remember, just because you do everything right, you're still looking at a lot of times an over 50% mortality if you do everything right. Shockable, out of hospital, cool them. You still need to tell the family they're probably going to die. You need to start that discussion early, because even when you do everything right, you're just making it less deadly. You're not even really getting over 50% a lot of times, all right? I went over, sorry. Any quick questions? Fantastic.